Hey, folks, welcome back to the podcast. My guest today is, well, I think all my guests are great. This guy is exceptionally great. His name is Dr. Gus Vickery. He started off in family medicine and he has evolved into the precision medicine guy. He uses all the amazing tools that you can imagine, including peptides, including he's now starting to weave bioregulators into his practice. And of course, all of the amazing tools like genetics, labs, blood work, you name it. But what we talk about in this podcast, we cover a lot of ground. We talk about metabolic health. We talk about the markers that you want to keep an eye out for. We talk about body composition. We do touch on genetics, but really we also get into some post-COVID protocols. He himself, along with his family, just came through COVID. So he was very generous in talking a little bit about some of the tools that he's tapped into to help himself and his wife get back to 100%. And then we talk about peptides for musculoskeletal issues. He has a really amazing story of how his daughter, who suffered a pretty serious tendon injury a year ago, had amazing results with a specific peptide therapy. So all that and so much more in this episode. If you want to find Dr. Vickery, it's drgusvickery.com, and that's Dr. Dr. The next thing is he's offered a free ebook to the audience. As he says himself, if you're an advanced biohacker and you're already up on this stuff, this may not be the book for you, but if there's anybody in your life you want to introduce to some of the more foundational concepts of optimizing your health, then this might be a really great way to do it. To get that book, to download it for free, it's ebook.drgusvickery.com. Doctor's being spelled DR, not DOCTOR. So that's it for my piece. Enjoy the episode. Of course, if you get value from this episode, please make sure that you leave us a review and share it out with your friends, family, anybody that you feel would also get a review. And if you're looking for me, you can find me through my website, natniddam.com. Thanks so much for being here. I appreciate you guys. Enjoy the episode. Hey, folks, just a little bit of housekeeping before we launch into the episode. Please remember that all of the information provided in these podcasts is for information purposes only. We are never offering treatments, cures, whatever for any kind of disease or medical condition. Anything you hear about here is going to be intriguing. There's some research around it, but make sure that you check with your medical provider before you go off and do any of this stuff for yourself. All right. So, enjoy the episode. And also, if you're looking to connect with me for any reason, with your comments, questions, whatever it may be, you can reach me through my website, which is natniddam.com, or you can find me on Facebook in the Optimizing Superhuman Performance group, or on MeWe in the Biohacking Superhuman Performance group. And of course, you can also follow me on Instagram, which is at Natalie Niddam. Natalie is with an H between the T and the A, the second A. So thank you so much for being here. Appreciate you guys. Enjoy the episode. Welcome to the show, Dr. Gus Vickery. It is such a pleasure to get to talk to you again today.
Thank you so much, Natalie. I am excited to talk to you as well.
Yeah, well, for you guys, if you skipped the intro on this one, which hopefully you didn't, but if you did, Dr. Gus and I met for the first time at the Wild Health Summit last October. And I had the pleasure of listening to his presentation, and which I think was before or after I talked about bioregulators. And then we had an amazing conversation after. So I think I knew then that I wanted to have you on the podcast. So I'm so excited that you reached out to me recently and we reconnected and this is happening. So I think that the first place I really like to start with people, but we have so much we want to talk about in this episode that I don't want to spend too much time on this, but I do love to give people a little bit of background on my guests, and particularly when it comes to medical doctors, about how they got from what you're taught in med school to where you are today, which are two very different places. So if you'd like to give us a little bit of insight on that, that would be amazing.
I'll try to keep it brief. So I I trained in family medicine originally and looked forward to just being a good old community doctor, seeing babies to older people, and felt like a very useful skill. I really enjoy people and getting to know people. So I started my own practice post-residency, which is not commonly done anymore. It was just a very small practice, and then grew that up over the past 17 years. And about 7 years into my career, like a lot of clinicians, you're just studying the population of people who are coming to see you. And you're recognizing that people really aren't doing well. They're not healthy. They're experiencing either symptoms of poor health or they have diagnosis, chronic conditions. And you're treating them with the tools you've been given, which are medications and maybe some lifestyle advice. And what you see is that they'll temporarily improve and then they get worse, right? And so you start realizing pretty quickly that other than the acute things that doctors can fix, brain and abscess, so a laceration, admit somebody to the hospital because they're having a stroke or a blood clot, that everybody else, you're really not doing a whole lot for them. I mean, you're helpful, but you're not really solving their problems. Not that we can solve their problems, but you're not leading them to the true solutions. And at that point in a doctor's career, you've done so much of what you've already been doing, you have some more bandwidth. And so you start having the ability to kind of follow where your curiosity leads you. In the first place, it led me was nutrition, of course, and then biochemistry, and then genetics, and blah, 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 right? Just started finding myself always taking additional courses and learning more about the human system, its design, and what's going awry in our modern times. And then in little ways, I was able to apply it in my clinic. So I'd have, still 20-minute encounters because I was doing the traditional high volume family medicine, seeing thousands of patients every year. But some of them would listen and they would try some of the things I taught them, even little things just like time restricted feeding or, lowering their carbohydrate intake. And we're talking 10, 11 years ago, right? So these were really novel ideas at that time, adding some omega-3 supplements. And what you saw was that people would improve, they would feel better. And, there's one assumption that the traditional healthcare system makes, and I work in the traditional healthcare system, about individuals that are chronically sick. And one of those assumptions is that they're not necessarily interested in getting well. I'm not saying everybody's making that assumption, but the assumption is that they're just okay living with these chronic diseases and they're just coming in looking for more medication. And what I learned over time is that was not true. I mean, there are some people that are attached to the sick role and they're just going to play that role for whatever reason. But most of the people I was seeing, they wanted to get well. They wanted to feel better. They didn't want another medication. They didn't want a pharmaceutical that could just take away the headaches. They wanted to figure out why they were having headaches. And if you gave them the right information, and that was the hard part, was what's the right information, they would take action. And they would get better and they would heal. And then over time, people asked me for more time, more data. And so I would do that. And then it just kind of naturally evolved to a point where now I end up spending all my time with a ton of data and also a lot of time with every person that I work with. And so I do this deeper level of medicine for the patients I'm working with. Some are very healthy, but want to be as healthy as possible. And some are pretty sick and need to restore health. But the good thing was that I brought young colleagues join my clinic that are a lot like where I was 15 years ago. And so we still were able to serve about 5,000 people in our community with an independent family medicine practice, take their insurance and really help them have a good experience and maybe get more. And then the individuals who really want to dig in and go deep and spend a lot of time will work with me in my program that's within the practice.
That's amazing. I love it. It's a natural evolution, right? But it's the natural evolution that happens for a medical doctor who actually takes that moment to say, wait a minute, what I'm doing is not working. There's a better way. And I think that, I don't know, I wouldn't call it lack of interest on the part of a lot of other conventional docs, but, either they're too overwhelmed or they're too swamped or, I'm sure there's a variety of reasons for a variety of people why this doesn't happen, but it's always, I think it's encouraging to see how an increasing number of physicians are taking that initiative now and saying, okay, wait, I graduated med school, but I'm not done. I'm not done learning. And there's more to this than meets the eye. So anyway, so we're all super lucky that you're doing what you're doing. So you talk about two distinct populations of patients that you serve. And I'm sure there's nuance and a lot more in there, but you basically have your patients who are sick, dealing with issues. And what you're doing is really trying to get them back to some degree of stability or homeostasis, we might call it. And then you have your patients who are not sick, but they want better. And so this is where we get into that discussion around longevity, high performance. And so, two of the big things we were going to talk about today, which I think are big topics that we're all still continually learning about, is metabolic health and body composition. And maybe we could talk a little bit about how we can start with metabolic health and how that fits into this conversation around longevity and high performance. Because I mean, we both know if you don't have that fundamental balance, those balances in your system in place, getting to the next level is just not really going to happen. And I think what we see a lot of is people hear about these really cool things out there, like the biohacking, the supplements, the technology, the peptides, whatever it is. And they want to just jump right in there. Right. And sometimes, you know, even as a coach, I find myself putting on the brakes and saying, well, hold on a second. What's the landscape you're going to be introducing these things into? So maybe you just, if you wouldn't mind, like just talking a little bit about these issues around metabolic health, because there were so many interesting points you hit on in the podcast we did before the podcast. I kept thinking I should turn on record.
Yeah. Well, you know, one of the obvious reasons why metabolic health became so interesting to me was that throughout the thrust of my career, the vast majority of people who were coming to see me frequently had type 2 diabetes, insulin resistance, hyperuricemia, lipidemia, vascular disease. And those things all collect around the same, under the same umbrella, metabolic health issues. And people are like, well, what is metabolic health? And, you know, there's not like a precise definition, but from my perspective, it's fundamental to all health, including longevity. It's your body's ability to take in everything needed to create energy, distribute it properly, right? Actually then create energy from it and dispose of the byproduct of that. Like if you can't do that, your cells can't function well, your tissues can't function well, you can't function well. And a lot of folks are shocked that when they just reverse like the beginnings of insulin resistance. So like you do a full lab assessment, they don't really have blood sugar issues yet, but they do have clear markers of insulin resistance. And you begin to clean that up through lifestyle change, et cetera, at how much their energy improves just by doing that, right? Not even doing any of the next level stuff. All they did was simply improve metabolic health. And now their brain's functioning better. Their workout performance is better. They're naturally losing weight without thinking so much about weight. And if you're not attending to this issue, one, in our time, going with the flow in our society, it means you will have poor metabolic health. And you're likely to have that by the time you're a college student. We already know studies when you do, say, glucose and insulin tolerance tests on individuals where it's much better to pick it up early, that like 80% of sedentary college students already have insulin resistance, at least at the level of the muscle cell. Maybe not yet the liver, maybe not the fat cells, but the muscle cells are already insulin resistant. And they can reverse that with just exercise at that stage, right? All they got to do is go exercise some and they can already reverse it. Then you get to 30 and you got to do a little more, and 40 and a little more. And a lot of folks also don't realize that, you know, the development of glycemic variability issues and insulin resistance is not just a product of poor lifestyle. It's a product of aging. Right? As we age, resting blood glucose goes up. It just happens. Our body is not as effective at managing that. And you and I both know through our genetic training that you also can have a lot of genetic polymorphisms that even increase that risk even more. And so I have some very healthy, still competitive athletic individuals that are in their 70s, optimal body compositions, and they're doing all the things that they're supposed to do and recovering and resting properly. And yet they have markers that there's some insulin resistance in their system. It's probably genetics and age, and we have to be very proactive about that.
And so how do you address that? So in some, you know, because on paper, and that's, you know, first of all, your comment on university students, I think is really interesting, because university students, because much of the time they can maintain that outward sign that everything is fine, which is that their body composition is basically okay. Nobody even thinks about it, right? Nobody thinks to check their blood sugar disposal management system. Like they just, and I actually think that's such an interesting point, because not only, to your point, are they setting up down the road, but could we say that it might even be in some small way impacting their ability to function cognitively at their best, right? And so how are they getting to those initial stages of insulin resistance? Could it be the crappy diet, the poor sleep, the drinking? Right? And plus you're talking about the sedentary student. So you're not talking about the varsity level student here. You're talking about the one that's the more academic version.
Yeah, I'm talking about folks who go to college but are not overweight, but just don't exercise regularly. They're not physically active. Yeah,
that's really interesting. So if anybody's listening to this and you fall into that category, or you have someone in your life in that category, I think that's a really great point. And I think it's something that we spend zero time talking about. And these are the people that, you know, they hit their 30s now, they've got the job, they've got the kid, or the kid's on the way, and it just starts to pile on in a big way.
Yeah, the average 40-year-old that I see has, and they don't have no idea, but when we put them on our DEXA, the visceral fat, the composition that they have, they're really shocked by it. Their body fat percentages are always higher than they would have estimated. Why? Just like you said about university students, they all most of them aren't manifesting a phenotype yet where they look unhealthy, right? But they don't know what's going on biochemically. Well, the average 40-year-old, all of their friends that they're hanging out with also have the 20 or 30 pounds of visceral fat. So they all look, they don't look obese, right? They look like the normal person, and they have no idea. And when you do the deep dive on their data and you look at their fasting insulin, their lipids, their inflammation, they're just shocked about what's going on in their system.
Yeah, that's amazing. And so, but the other thing that you said that I thought was really interesting was the 70-year-old, and this one's tougher, right? Mm-hmm. Because it's easier with the university student, 20-year-old, 30-year-old, 40-year-old to say, okay, well, let's introduce you to the concept of eating better, sleeping more, drinking a little less, moving a bit more. Like, we're still at that point where, assuming they didn't do damage to themselves by crash diets or all the crazy things that people do, this is still a reasonably easy fix for the most part. But with your 70-year-old who's very physically active, who's very fit, who's a competitive athlete, and yet who's showing those signs of insulin resistance, at this point, you're not going to tell them to exercise more. You're not going to cut their carbs anymore because they're already eating reasonably well. So what's the solution for that guy? Like, what are the levers you're going to have access to in this situation with that kind of insulin resistance building in the background?
Yeah. And so to your point already, so we know that they're getting proper sleep. We're tracking that, right? Because if they're not recovering, if they're athletic and overtraining, because that's just a habit, then that's going to actually impact, these systems. So we're just going to pretend that this person is recovering properly. They're sleeping well. They've got a very healthy diet. They're using the proper principles of time-restricted feeding. Their circadian rhythm's working well. And yet we're checking their markers, and we can clearly see that they're developing, say, higher glycemic variability by looking at their A1C and blood sugar data. Now, one thing to always look for, of course, is, are they having some beta cell attrition and function, right? Because a lot of times it's going to be both at those ages. It's not just that they're insulin resistant. It's also that their beta cell production isn't what it used to be, and they're not able to handle a higher glucose load at meals. So you were right that we're probably not going to necessarily cut carbs, because these people are probably already eating complex carbs and eating healthy portions, but we may. Some of these individuals may have to gravitate towards more of a ketogenic diet and just do some carb cycling if that's where we need to take them. And that will usually work for these individuals. That's where we also have to, because there's a delicate balance of getting enough protein, which you and I both agree is critically important, that most people aren't getting enough protein. Preservation of your lean mass as you age is critically important for a healthy longevity. And so we have to get the right amount of protein, but even when you eat just normal protein, like regular amounts, a certain percent of that will go into gluconeogenesis. Always happen. Right? You can maintain your glucose through protein. And so that's where we'll use a continuous glucose monitor. It makes a huge, huge difference, because then we can really get precise on what exactly is triggering the glycemic variability issue. And you can really figure out someone's carb tolerance and protein tolerance and understand how to craft their diet. And if somebody is willing to get that level of data and they're so committed, they'll do whatever they have to with their diet, they're still going to get to eat plenty of tasty, good food. It's just going to be different foods. We can usually fix it through diet, but we'll usually have to also use some type of agent, whether it's a nutraceutical or whether it's a pharmaceutical. If they're a good responder to metformin, it's a great drug for these folks. It can make a huge difference, especially if insulin resistance is the issue. So we'll go ahead and start them on metformin and see how they respond to that. And then, of course, berberine, bittermelon, some of these other options can be really quite helpful for them as well. And then we also will look more carefully at the gut biome, right? Because that can make a huge difference on insulin resistance. And we'll look at balance and diversity, but plus some of the specific species. And we might try to target interventions to the biome and see if that might have a measurable impact on this. And then if there's a beta cells issue, what you taught me At the last conference, after I presented a really interesting metabolic case, a woman who went from a hemoglobin A1C of 15 to 5.8 in 6 months, who had LADA form of diabetes, was considering bioregulators, right? Bioregulatory peptides that might provide some restorative function to the pancreas. So that's where I've got to go next in my understanding and learning, which I hope you'll be able to help me with, because I think some of these stacks of bioregulators could make an enormous difference for these individuals.
For sure. And it's funny because I was going to bring you back to the beta cell function, only because I was concerned that some of the listeners might not make the connection between beta cell and pancreas. So the beta cells are the cells in the pancreas that are responsible for making insulin. And as we age, they can get tired. We can lose some, there's attrition, there's damage to the pancreas for whatever reason. And I think you're right. I think that this is where bioregulators can provide a next layer, if you will, potentially to help to restore function, restore health, regenerate these different tissues and organs, and whether it's the pancreas or the blood vessels or whatever the case may be, just understanding that they're less of maybe of an acute intervention, in the sense that you're not going to just take the pancreas bioregulator and next week see better beta cell function, but over time, what we might see is a restoration of that function. And I think, for someone like you to be doing this because you're so into the data, it'll be very interesting to see how over the next, and I'm going to say the next year, because it's going to take time for you to start to tease out the effect. But with your patient base, because you're so data driven and you're looking at this stuff and they're doing everything else right, I think it's going to be really fascinating to see how much how much impact you're going to see from the bioregulators in your practice.
Yeah, I'm really, really excited about this class, Natalie. I can't wait to dig in. I feel like it's going to be a next level healing opportunity for so many people. And I think we'll both agree also, it's something that's going to be affordable, something that they have access to. They're not going to have to spend thousands and thousands of dollars to go to, get all the next level and stem cells. I'm all for that. Like regenerative medicine is amazing. I love looking at what it can do. But actually, most people I work with just aren't able to access those levels of therapeutic shed. And if we can work with natural compounds, which these are natural compounds that are reasonably affordable, these stacks over time are affordable, then a lot of people are going to be able to experience either healing or healing and then optimization in a way that hasn't been available to them previously.
Yeah, I love that. It's really exciting. Okay, so one of the things we touched on very briefly on metabolic health, unless there's anything else you want to get into there.
Well, the last thing, and it is the little tip, and most people probably know this, but for that 70-year-old or for anybody who's trying to better control, mealtime glucose, postprandial glucose, we do know that if you will do some more vigorous exercise right before you eat, activate your muscles, because that's your biggest glucose disposal tissue in your human system, deplete a little glycogen, then you eat, and then you go take that walk 20, 30 minutes later, and you upregulate non-insulin dependent means of glucose transport into muscle cells, you can make a dramatic difference on your blood sugar.
Yeah, no, I love that. And that's a great takeaway. And actually, what the image I have of that, which I will forever have, is when I read The 4-Hour Body by Tim Ferriss. Did you ever read that?
Yeah, I did.
And he talks about how he describes himself in the bathroom stall in a restaurant.
Yeah.
Doing like 50 air squats before his meal. I think that image will never leave me.
I know. And when some of the people I share this with, they're going to feel silly doing this stuff. And I'm like, don't, right? Like if you can get better glucose control, the compounding effect that will have for you over time is enormous.
Yeah, no, it's huge. And it's nothing, right? So it could, and to a lesser degree, although it's not going to deplete glycogen per se, even making the decision to walk to the restaurant and then walk home after dinner, which is a very European thing to do. If you think about it, it doesn't so fit into our North American sensibility for most people, but think about it. Like we do this sometimes. And even though it's like winter and very cold, you kind of bundle up and it's kind of hard to push yourself in the cold and the snow to do this, but you're always happier when you get home. You sleep better. right?
And your digest is better, right? After you eat a lot of food, you take an easy walk and digest, contract your stomach muscles, which helps, move things through bowel. I mean, as opposed to just sitting on the couch feeling full.
Feeling like a beached whale.
Yeah.
Yeah. All right. Well, that's a great little takeaway. So moving on to body composition and optimization, because body composition is a direct offset of metabolic health. But one thing that you said earlier that I think is really important that people sometimes miss is I think we sometimes over rely on how we look on the outside to determine what's going on the inside. And so it's easy to look at someone who's overweight and say, oh, you're overweight. You got something going on and, you're not disposing of your glucose properly. You're not making enough insulin. You're eating the wrong food. You're not sleeping. But sometimes we look at these people and they look fine. And this is our classic skinny fat person, I guess, is the person who looks fairly trim on the outside and yet there's all this other stuff going on the inside. And so we've mentioned a few times these metabolic markers, maybe we could tell people a little bit of what are those precise markers they should be talking to their doctors about looking at, saying, what is it that I should be what am I looking for when I'm looking at my labs?
Yeah, I think it's great. Yeah. And did I interrupt you? Did you have anything?
No.
Yeah.
I'm good.
Yeah. And also just so you know that blood work can get expensive, but this particular blood work doesn't have to be expensive. And even if your insurance isn't going to cover it, typically you can get it for what we call client bill rates at a very reasonable price. So a lot of folks are shocked when I say this because they're thinking about glucose, but usually insulin resistance will show up in lipids before it shows up in glucose.
Nice.
Right? So looking at your lipids and not just your standard cholesterol profile, but getting particle distributions can teach you an enormous amount about where your human system is. In fact, a lot of the folks that I see that are already 50 and they're overweight, yes, we'll measure high insulin, probably a borderline to pre-diabetic A1C. But a lot of the younger people that I see, their blood glucose, hemoglobin A1C, and insulin still look fine. And if that's all we use to assess insulin resistance, we say, oh, you don't have insulin resistance, but that's not enough. But long before it starts showing up in those particular metrics, it's in the lipids. And what we specifically look at with the standard cholesterol profile isn't so much the cholesterol, but actually, of course, the HDL and triglycerides in those ratios. I like to see a triglyceride under 75. The normal range is less than 150, but my target for my patients is less than 75.
Right.
And
big difference.
And then HDL, which does have a lot of genetic influences. There are some individuals that are just going to have low HDL, but the higher the HDL, the better. But there's a lot of mystery around HDL right now. We're still not quite sure where the risk is and why it might be protective, if it even is. But looking at that ratio of triglyceride to HDL and having that be under 2-to-1 is really, really good. Under 4-to-1 is considered normal. I consider 4-to-1 too high. So that's the first place I look. Then if you can get either through an NMR study or just simply a spot check an LDL particle count, and then really the small dense LDL, which is important for a couple of reasons. Arterial health is critically important, but also the percent small dense LDL, which is calculated. If you get a small dense LDL and you have an LDL, you'll get your percent small dense LDL. That's usually the first place I see it. Even before triglycerides rise, the percent small dense LDL starts going up. And as your body starts making smaller, denser LDL particles, that does appear to be an indicator of many potential things, but definitely insulin resistance. So I look at small dense LDL, I look at LDL particle counts, HDL particle counts, and if you can get a full NMR, then you're getting the sizes and distributions across the whole LDL spectrum of particles. And then I look at triglycerides, HDL, and those ratios. The fatty acid balance can be really helpful. It's a little bit different because it's really just a status test. And the one I use is done on cell membranes, red blood cell membranes. So it's about a 90-day assessment of the balance of fatty acids in those membranes, which is a reasonable proxy for your overall balance of fatty acids in your human system. It's not perfect, but it's reasonable. And you're going to look at your saturated fat percent. That one's a little challenging because it can be endogenous or it can be exogenous. So some folks will have a very high saturated fat percent in their cell membranes, and that's not good for cell membranes. It can make them rigid and inflexible. And, and so while I do the inventory, turns out they're not eating a lot of saturated fat. Well, we know then their liver is producing a lot of saturated fat. And in that case, they're likely insulin resistant. Yeah, that is part of it. Or drinking too much alcohol, because that'll do the same thing to you. Yeah.
Right.
Yeah. And then we look at their, of course, omega-3 levels, which are commonly deficient. And then we look at the linoleic acid, which is a really interesting biomarker, because we don't have any human data as far as I know, but we have mechanistic data that higher levels of linoleic acid in a human diet influence appetite. It dysregulates satiety. It makes us hungrier. It can adjust the lipostat and the hypothalamus up, meaning you can actually gain more weight. You can adjust your personal fat threshold up. So if you are overeating, you might store more as fat. It also influences insulin resistance. And it is a base compound for arachidonic acid, which is an inflammatory eicosanoid, right? So there's a lot of things going on there. And we do know that our modern diets have much higher levels of linoleic acid than our ancestral diets. It is an essential omega-6 fatty acid. It's important. We should have some. You don't need to eliminate it. 90% of the people I test, their levels are sky high through the roof.
And out of whack with omega-3, right? So the linoleic is way too high and the omega-3 is way too low.
And that's highly problematic. And right now, all I can do is just follow my own data. I'm not going to hurt anybody by helping them reduce seed oils and maybe eat some less nuts and seeds, not eliminate them all, but, minimize those things and optimizing omega-3. So I feel these are safe experiments to run. What I can tell you over the last 2 years is those fatty acid balances have begun to optimize, saturated fat optimizes, trans fats optimize, and we balance those omega-3s. And it goes from all red to all green on the little flow chart. Yeah. It's amazing. The spillover effect on the rest of the metrics is just mind-boggling. The lipids, the small dense LDL, the cholesterol production markers change enormously. The insulin resistance markers. It's crazy how much positive change I see as we fix those things with the fatty acid balance. Again, I can't produce, all I can give are anecdotes. But, if the data shows that this human system is much healthier and they feel better, then we feel pretty confident we're doing something good for that person. And then finally, there's the other metrics we talked about: an insulin level, a glucose level, potentially a C-peptide level if you're questioning pancreatic beta cell function, and a hemoglobin A1C. Hemoglobin A1Cs can be off if they're anemic or they have what we call erythrocytosis or high red blood cells. A lot of folks on, say, testosterone therapy may end up having an increase, and that can skew an A1C. So you have to put that into context. And then you can look at other markers like fructosamine, but that's only about a 2-week average. I don't usually get those. But, you can see it there. Obviously, if you can do a glucose tolerance test, that's the best thing to do. And you can do this at home with your own like Freestyle Libre or a glucose monitor. You just take a 75 gram of sugar glucose into your system, and you can buy that at the grocery store and you measure it. I like to measure it 30 minutes, 60 minutes, 90 minutes, 120 minutes, and see how your body is clearing that glucose. That it can give you great information. It might be one of the best tests you can do. And then finally, there's some peripheral markers that may or may not be elevated that can indicate insulin resistance. Uric acid can commonly be elevated for people with visceral fat insulin resistance. Ferritin, which is a protein iron complex, can be elevated in cases of insulin resistance. So what you do is you get, each of those markers, and I could write those down if you want, put it on a little sheet that I can send to you, and then you can make that available to your listeners so they don't have to try and remember all this.
That would be great. Thank you.
Yeah. And what you do is you have to look at the whole collection of them. Right. And then that will really give you the picture. And obviously, if they have a hemoglobin A1C of 6.3 and a fasting insulin of 30,
there's a problem. It's pretty clear. And I think you also mentioned testosterone therapy, which is really interesting, because I think what that brings into play is it goes back to the complexity of the system and making sure that you're looking at all the different factors. And hormone status is going to be a factor in this, just like the lifestyle stuff we were talking about before, like the exercise too much, too little, the sleep not enough, the stress levels off the charts, or are they being managed properly? Just making sure that we're looking at this whole thing. And I'm sure that, I know that you also look at hormones as part of this whole thing, but in the interest of time, because there's lots of other things we want to talk about, and maybe we're just going to have a part 2 episode. This is great. And I think the link to fatty acid status is really interesting. And we talked about inflammation in that as well. But, I think that just helping people to understand this whole view. And one thing I wanted to ask you about was your opinion on LDL, because there's so much conflict out there about this stuff. You've got some people poo-pooing LDL and saying, you need LDL, all this garbage. It's just the pharmaceutical companies trying to sell statins. And then on the other side, you've got medical doctors who go, yeah, but no. Turns out if you've got sky high LDL, it's not going to serve you well. And it's about those ratios. Again, like it's all about ratios. And I think the VLDL, which is the small, hard particles of LDL, I think everybody can pretty much agree are going to be a problem, right?
They're going to be a problem. Yes. So yeah, it's a great question because it's a controversial topic. And I do like to follow the different thought leaders in these areas. And there's some brilliant people breaking it down. The great thing for me is when I'm working with an individual, I just have data, I have context, right? And so I don't really have to think so much from a population health level. Should we be lowering everybody's LDL? All I have to ask the question is, should this individual have a lower LDL? And so of course, once we look at those lipid distributions again, and especially if they genetically produce lipoprotein A, LP little a, that's a whole different ballgame. If they produce a lot of LP little a, their risk of vascular disease, blood clots, and aortic valve disease is much, much higher than the general population. And we have pretty good data that lowering LDL in those individuals is likely to forestall the development of atherosclerosis. So every listener, just pay attention to this. This is not being routinely checked right now. It's a $4 test. It's called lipoprotein A, or LP little a. Somewhere between 15 to 20% of the population express it. I do. I express high levels. Can't help it. It's genetic, not lifestyle. And if you do, you need to know, because the way the lens that you're going to look at your arterial health through is going to change if you express it. It is important to know there are subtypes of LP little a, and we can't subtype them all yet. Some of those subtypes will be harmless. Some are obviously contributing to disease. And if you have it, you need to know. So if you have LP little a, that's going to change things. If when I do your cholesterol balance test, you have sky high plant sterols like cystosterol, sitosterol, right? And your genetic risk for plant sterols is high, then that could be a contributor to the development of arterial plaques. And we may need to mitigate those. It could mean that your LDL is more problematic, but of course, we're going to use a different treatment pathway in that particular case. Then we're going to look at vascular inflammatory markers, oxidized phospholipid on ApoB. If that's high, there's something irritating your endothelium. And if your LDL is high at the same time that your endothelium is injured, you're going to end up with some plaque formation. It's going to happen. Yeah.
Well, it's a healing mechanism, right? Like, I mean, at some level.
It's a scar. It's a scar. Yeah. And so we look at all of those different labs. Are you insulin resistant? Or do you have chronic inflammation, independent of vascular inflammation? And then, of course, we'll go get objective data. Let's go get a coronary calcium score and see if we can see evidence of prior healed plaque formation. Let's get a carotid IMT and see if we see any soft plaque on the surface. For those who can afford it, we can get a CT angiogram and see soft plaque in the coronary artery system. Because if you have soft plaque, you're still forming plaque right now. Right? So when I have all that data, then I can decide, hey, yeah, we better lower your LDL. Right? We're gonna buy you time with your arterial health if we lower the LDL. How do we choose to do that? There's a lot of ways to do it, but we may use statin medicines. They are phenomenal at lowering LDL cholesterol. And we'll follow all these metrics while we do it. And I have patients who had high LDL and high small dense LDL and who had high oxidized phospholipid on ApoB and LP, blah, 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 significant calcium scores, the high production markers for cholesterol. We put them on statin therapy, and guess what? It all became beautiful. Right. It all came, So the statins also have some form of anti-inflammatory effect at the level of the endothelium. Right. So in those individuals, one therapeutic, a statin, resolved the inflammation, lowered the LDL, subsequent calcium scores 2 years later, no progression of plaque. Well, wonderful. I'm so glad we have statin medicines to treat these individuals with.
Yeah. I love that. I mean, I think that again, because of the controversy, people get so polarized and you get so many, whether it's doctors, practitioners, whatever, demonizing statins. I mean, yes, they're not the panacea. No, everybody doesn't need to be on a statin. And to your point, in some cases, thank goodness we have them, because they are the tool that is necessary for this individual, given how they roll. I mean, I have a very good friend right now who's in her early 50s who just found out that she's got 85% blockage in a coronary artery. Like, that's scary, right? And it just popped up.
Yeah, that's that age in a female. She better ask for an LP little a test. I wouldn't be surprised if she doesn't have that lipoprotein.
Yeah, well, yeah. So that's a whole other conversation. So moving along
Yeah.
on our list of things to talk about, because I mean, even if we stop now, I think there's so much gold in this conversation, but there's a couple of other conversations that I think people will be really happy that we touched on. And one of these, and I think it ties in a little bit to inflammation, maybe, but the scourge of our last couple of years being this new virus that's made its appearance in our world, COVID-19. And I think what we'll do for both our sanity is we're going to stay away from all the politics and the conversations around COVID. And all we're going to talk about is reality. And I know that, well, two things. Number one, you've been working with peptides for quite a while. You and your whole family have recently had the pleasure of doing the dance with the virus all together. And so both before that and now since then, you've developed some protocols around this inflammation that just seems to stick around after people, for some people at least, after COVID-19. And I would guess maybe with a lot of people, whether they recognize it or not. And I'd love for you to talk about your situation, because to your point, you're mostly fine, but your bar for being fine is a little different than the average bear's. And so therefore, you're not at 100%. So maybe we could talk a little bit about what you're seeing in your patients, what you've seen in yourself, and some of the strategies that you've maybe tapped into to help people through this. And, I don't think we're going to really talk about long haul COVID unless you want to, but it's up to you. I'm going to let you go with this one.
Yeah, thank you. I think this is such an important topic because so many people are dealing with this, whether they're dealing with a more severe long haul COVID or they're dealing with minor residual issues associated with it. And it is lingering. The effect in the system is lingering. And, you can't always measure that. I've had a lot of patients who clearly have post-inflammatory syndrome, but their cytokines look fine. That doesn't, but they still have inflammation. We just can't measure them. But I've also seen a lot of individuals who have measurable interleukin-6, which is a very powerful inflammatory cytokine. And it should not be elevated in a normal resting state, right? And we know also interleukin-6 is also the cytokine that was most associated with the whole cytokine storm and the crashing people had. So the fact that we can assess that is really quite good. So my family, unfortunately, we got to dance with the Delta variant before it cleared down and before Omicron came in. And it's a nasty virus. I mean, it definitely isn't a fun experience, but we're all fine. We're all healthy. We're all fine. We were very proactive once we realized what we were dealing with the whole supplement protocol that, people recommend. And thankfully I had available at the home thymosin alpha, thymosin beta, BPC, and immediately started everybody on the protocol. Not my kids, they're healthy. They bounced out of it pretty quick, but my wife and I, but I did, as I shared with you, I can see data points that have clearly changed since I had COVID. And that was a month ago now. One is my deep sleep scores have still not recovered. I measure that, I track it. They've been the same for 3 years, and now they're 70% less than they were. And I can feel it. I don't feel quite as rested when I wake up. They're slowly getting better. I can see them slowly responding. 2, I can feel a little more inflammation from my workouts, my weight training. It's taking me a little longer to recover and feel like I'm bounced back and ready for more. And then I did a full blood panel on myself recently. I just wanted to check. So I did everything. And it was interesting because since the first of the year, other than through COVID, where I lost 7 pounds, not eating, not tasting anything. But, if anything, that would be like a fast. So it should have been healthy.
Yeah.
And I've been very tuned in on my habits since the first of the year leading into COVID. I've avoided all alcohol. I've been eating very clean. I've been very well programmed, the usual New Year's stuff. So my blood work should look really, really good right now. And I had some blood work done towards the tail end of last year. And even my lipids were really, really skewed. Like my small dense LDL was up, my cholesterol production markers were up, my LDL had shot up significantly. It had looked just beautiful a few months ago. I've not been, and my diet again has been, if anything, lean and that kind of stuff. Ferritin went up like 300 points.
Wow.
Yeah. Oh, I know. It was really interesting. Hormonal changes, lots of little this and that if you didn't have context, you would just be kind of guessing at what's going on here. But me knowing myself and comparing that data to not long ago, I know that that's an after effect of COVID, because you do produce more cholesterol during a time of infection or during inflammatory, right? So I know that those cholesterol changes were due to COVID, but they're lingering. right? And then the ferritin, absolutely, it's an acute phase reactant. That's an oxidative stress marker. That tells you that as well. And so given the fact that I can feel it a little bit, overall, I feel good. I'm happy. You know, if this is the worst that I have from COVID, then I'm grateful, right?
Yeah.
So many people have so much worse or far, far worse. But nonetheless, I like to feel good. So I had been digging into these protocols and guessing at things, really guessing with people, knowing that there's an inflammatory cytokine component. There's a mitochondrial component, right? We know that those two things are going on. There could be a detoxification component, but I don't know for sure. And I don't know how much biome disruption there could be from people taking a lot of potential, medications and things. Some people got on steroids and other things that could have happened. But so the layers for me are one, first, mitochondrial support, right? Mm-hmm. And of course, it's a big grouping of compounds that you can use for mitochondrial support: NAD, NMN, resveratrol, EGCG, carnitine. The list is long, right? Yeah. Phospholipid support, et cetera. There is a product made by a guy. I don't know if you're familiar with a podcast by a guy named Ari Whitten. He has a podcast called, well, his product Energenesis, which is his mitochondrial support supplement, I actually think it's just the catch me out of mitochondrial support supplements.
No kidding.
Yeah, he took every studied ingredient and put it in there at exactly the doses that have been shown to benefit mitochondria. So rather than trying to guess, like you and I, we've studied mitochondrial genetics. So we could look at sirtuin genetics, we can look at NRF2 genetics, we can know which aspect of the mitochondria needs support versus which ones are probably well tuned. In this particular case, you're just covering every one of those.
Which I think is smart.
Yeah.
Right. Because when something goes out of whack, one thing about mitochondria, I just finished a course with Joel Green, and he did a 2-hour lecture on mitochondria, which was really a 5-hour lecture crammed into 2 hours, which is kind of how he rolls. And I remember at the end of the 2-hour lecture, and he may even have finished with this saying, this is what we know about the mitochondria. I can tell you that there's at minimum double what we don't know.
That's right.
Based on spinning off of what we do know. So right. I think that to say that, this is off, but this is not off. I think at this point, just take care of as much of it as you can and hope that the downstream effects just cover the rest of the bases we don't know anything about.
That's exactly right. Yeah. So my combination naturally has been, if they'll do it, I'll have them order his Energenesis supplement, because I really do think he's just covered it and it's all there, and you don't have to go try and find all these different components. It has D-ribose, it has everything in there.
All the things. Yeah.
Yeah, it has everything. And then I'll have them, of course, increase their omega-3s while they're doing this, because I have had optimal omega-3s and I take omega-3s and I eat fish, and my omega-3 index was reduced by like 3%. I don't know why. I don't know what effect. Even while I had COVID, I kept taking my omega-3s, even though I wasn't eating. So there's no reason why my cell membrane concentration should have dropped so much. I can't say for sure that was COVID, but why? How did that happen? But taking their omega-3s, obviously taking the vitamin D and optimizing that status. Oh, the other metric. So I checked my RBC levels of zinc and copper. Mm-hmm. And I was taking zinc, and I take a bunch of liver capsules on a regular basis, which should have a lot of copper. Both of them were significantly deficient.
Wow. So your body just chewed through that stuff, trying to deal.
Even with taking high dose zinc, which I don't do routinely, and taking what should be a healthy source of copper through that entire time, I was deficient in zinc and copper. So there you go as well. So I ordered a specific form of zinc and copper and have really amped up that. So again, I'm sorry, I keep going off on these tangents, but that was an important one for me to remember, because because we know that's going to influence recovery and immune system balance, everything.
Yeah.
Your T helper cell ratios are going to be highly influenced by those zinc copper amounts. So then we have the omega-3s, the vitamin D. What I have done is kept them on elderberry if they're using it, because of its immune support benefit. I feel like it's going to take a while for the immune system to recover. I've kept them on quercetin, like a really good form of quercetin. And then if they have it or use it already, I believe that different pathways for antioxidants, like hydrogen enriched water. So so I've really amped up my hydrogen enriched water. I use it occasionally, not a ton, but I just started using 2 or 3 of those little dissolvable tablets every single day. And then I found some studies on liposomal vitamin C. Have you ever studied that? Like theoretically to me, it didn't make sense that ascorbic acid, which is water soluble, that you couldn't just load up on that. But I found a really good study where they were using it in an intensive care unit, and they compared IV liposomal and oral ascorbic acid. Liposomal was clearly superior, and they proposed the mechanisms, bypasses gut limits and moves right across cell membranes and stuff stuff like that. So there's some studies showing ICU recovery is faster with 6,000 milligrams a day of vitamin C. So I had people order liposomal vitamin C and use as much as they were comfortable up to.
Yeah, well, and to your point with the liposomal, you don't have to worry about the gut effect. And I think, right. I mean, in theory, if you think about it, it should make a difference, the carrier.
Yes, it should.
It should make a difference that it's encapsulated in this little fat, in this phospholipid, and that it's going to get different places. And it's almost like taking something sublingually instead of swallowing it and having it go through digestion.
Yep, exactly. And then there's the next level, right? So that's the basic natural, all of that kind of stuff. And then get your sleep and be the other thing for athletes, don't push it too hard.
Oh, God.
This is going on for weeks after you had this infection. And the people who are like, they just went back into the gym and heroed up, they hurt, right? Why am I relapsing? What's going on? Do I have the virus again? You have to pay attention. If you track it, your heart rate variability, resting heart rate, respiratory rate, and when those metrics aren't back to baseline, sure, go get some exercise, but this is not the time. This is not the time to make progress in the gym. Do not go for PRs. You're just going to delay your recovery. That is critically important for people to understand.
Or relapse.
Yes.
I mean, I think we've all heard of people, as a matter of fact, who talks about this is Alex Tarnova, who is the Drink HRW founder that make the open cup molecular hydrogen tablets.
Oh, yeah. Okay. Yeah.
I recorded a podcast with him last year. So it was either Delta or the variant before that. And he said he was home kind of going nutty. He had tested positive. He was basically asymptomatic. Mm-hmm. And 10 days in, he kind of lost his marbles. He was so bored. And, there was something about a bottle of wine and a bunch of pizzas and a crazy workout and then another bottle of wine. And he said he got flattened by this thing.
Yep.
Like it like came up at him and his body was like, I got nothing.
Yeah.
And it took him out.
I don't, I never judge people, or I try never to. I'm pretty easygoing. People make their own choices. I'm an advisor. I've almost gotten angry about this one with a couple of patients. We were like, because they're writing me again. And what's going on? Why am I feeling like this? What happened to me? And then they tell me what they did. And I'm like, how many times do I have to tell you? You've got to respect what this thing did to your system. Stop. Yeah. Right? Yeah. Do something else. Be productive in some other way. Anyway, it gets me riled up. Yeah. And then there's the next level, the peptides, right? So I was using BPC, of course, and thymosin beta, as we shared earlier. Once I looked into some more data, I realized I was probably not dosing the thymosin beta where it needed to be for real, like repair and recovery. And so what I've done is place people on either oral BPC, 500 micrograms, and had them potentially increase it up to 1,000 and see how they respond to that, or even switch them to systemic and start doing injections, at 200 mics up to 400 micrograms a day. And then the thymosin beta, which I think is actually going to be phenomenal for this. I really do. I started doing the 1 milligram injections a week ago when I was figuring this out, and I already feel a big difference.
That's interesting.
Yeah. And so starting people on 750 micrograms to a milligram of thymosin beta 4 daily. And as you mentioned, even potentially considering the fragments, but that's a little more in depth than we can go into right now. But, those two peptides, I think, can play a major role. Now, there's a next level. If you can get access to it, this will help you enormously. Hyperbaric, right? If you have somebody or a facility that you can pay to go get hyperbaric treatments, it can absolutely help you get out of a residual COVID effect much faster.
That's amazing. That's such a good point as well. Actually, so you talked about the BPC 157 and thymosin beta 4. You use thymosin alpha 1 as well, right?
Yes, that's right.
In your protocol?
Yeah, I do. And I think of thymosin alpha 1, and this could be me not thinking about it completely correctly. I think of it more from the standpoint of balancing the immune system. Right? Yeah. And so I use it a lot, obviously, in people with autoimmune diseases and chronic Lyme and things of that sort. So for me, it's more of a prepare your system and hopefully not have as bad of a case of COVID. And honestly, even though I'm still dealing with residual effect, my COVID case was relatively mild compared to most people. And I had been using thymosin alpha leading up to it. And I do think it can help the immune system rebalance afterwards. So I think that it's not going to hurt you to continue thymosin alpha for some extra time after. But I think, but this is just a Gestalt thing. I think that the anti-inflammatory and reparative effects of the BPC and the thymosin beta are going to be more helpful for resolving persistent symptoms.
Absolutely. And I actually, I'm interested as you dig into the bioregulators a little more, also looking at the ones that speak to the vascular system, like the blood vessel
Yes.
bioregulator. Like we know, I don't know how much we know, but there's plenty of evidence that the blood vessels take a hit from COVID.
Yes.
And so anything we can do to support them, I don't know, again, if acutely you're going to see a massive difference, but over time, anything that's going to help those blood vessels to repair.
Yeah, I am so glad you said that, because I've also seen a lot of people with elevated fibrinogen, and many people, I've had cases of blood clots, right? COVID related blood clots. In fact, I had one guy who was on everything and the kitchen sink, who 12 days later, he came to see me. His oxygen saturations had dropped. I sent him over immediately for a CTA of his lung, and his entire right main pulmonary artery was occluded with clot. He had a massive pulmonary embolism.
Oh my God.
He was literally, within minutes, any further clot dissemination, he would die. And I had to call him and send him to the hospital by EMS. I was like, you got to go now. They got to get you on, thrombolytic agents. And he didn't want to go. He was like, can't you just put me on a medicine? I'm like, no. Got to go to the hospital. He was afraid if he went to the hospital, they'd put him in the ICU and put him on a vent and he'd die. And I was like, no, you're not going to go on a vent. Your COVID pneumonia is mostly, this is a blood clot. They just need to get you on blood thinners. So I've seen that, but a lot of folks will have microclots. They can't be measured with imaging studies. So they have just teeny clots throughout their system. And fibrinogen can be an indicator of that. And so a lot of the folks I've tested and post-vaccine have had high fibrinogen levels. And I can't say for sure that this is going to work, but one thing that could work is a fibrinolytic agent called nattokinase. Yeah. And so I am starting individuals on nattokinase. And I'm also, while they have COVID, until they recovered, if they don't have a reason they can't take it, like a 325 milligram aspirin.
Okay. Yeah. Just as a precaution.
Yeah.
Interesting. Great. Good point. All right. So COVID, we've got 2 more topics. Let's see if we can jam them in before we both have to fly. The next one is really interesting as well. And I mean, clearly, guys, all of you who are screaming at me, no, there's more to dig into on COVID. Yes, there will always be more to dig into, but this next one's really good. One of the things that when Gus reached out to me was talking about his daughter who had sustained a significant injury to her Achilles tendons, right?
So it was her ankle. She actually blew out most of the ligaments in her ankle,
perfect.
The lateral and medial complex, and then also had 2 tendon tears. One's the posterior tibial and the other is on the medial side of the ankle.
Okay. So, and we all know the tendons and ligaments are the worst to heal because they just have bad blood supply. And she's got to be young, like.
Yeah, she's young and she sprints and jumps and so it was a pretty bad injury. We did the conservative approach, physical therapy. I did start her on thymosin beta and BPC, just systemically, not locally. And 6 months later, when they re-imaged, the ligaments had not healed. So they took her to surgery, and the surgeon here did an amazing job of putting all those ligaments back together, because the tissue was kind of shredded. He had to use some pretty novel stuff like biological tape and things like that. So it was really cool. Got the ligaments all fixed. But what was neglected, and I don't mean this as a negative about him, he did an amazing job, but the 2 tendons that were originally torn, like significantly torn on the MRI, weren't attended to. And so stopped, she's recovering and she's doing her therapy, but there's still some issues. And a good friend of mine and an amazing foot and ankle specialist named Stephen Barrett, if you ever want to do a neuropathy conversation, he's your guy.
I'm in.
He's done TED Talks, he's written a textbook, and what he can do for restoration of nerves is amazing, next level stuff. So Stephen was coming through town to go to Raleigh to do his TED Talk, and he brought his ultrasound and he ultrasounded her tendons. And sure enough, just like the original MRI showed, big old defects in the body of the tendon, full of fluid. And my daughter's crying. She's thinking, oh no, I'm going back to square one. And he injects, he does a nerve block, and then he injects BPC right into each of those tendons. I watched him put the needle in there and slide that medicine right into those tendons. He said, stay patient, give this a little time. 2 months later, we drive to Atlanta to see him at his clinic, and he re-ultrasounds. Her tendons look brand new, 100%. Wow. It was night and day. Like, if I could show people the before and after images, it's mind blowing. Like just the health of the tendon, the body of the tendon, how it looked. It was remarkable. And these were tendons that 1 year later had not healed. Right? Yeah. And then 2 months after the injections, they're good.
Wow. Did you continue with systemic
Yes.
peptides after the site specific?
I did.
You did. Okay.
Yes, I did. I asked him, should I? And he said, yeah, just go ahead, keep her on it. So I did. I had her on the BPC capsules at that point instead, and I put her on TB4 injections.
Yeah, no, that's amazing. I mean, I find that it's those cases with the peptides that really, hopefully, is what's getting people's attention, because it's those cases you just can't budge, and they're the game changer, right? Yeah. Like, I mean, I had a client who is, she's in her 50s, I want to say, getting close to 60, unfortunately, a lot of inflammation, like not a good terrain to work with. And she had like, you could see there was a flap ripped on her Achilles tendon, which is a really nasty injury, right? So she had a physician who was doing PRP injections, and he was very clear with her, you're going to need 3 of these for us to even move the needle. But she'd met me, and with her brother, who's a chiropractor, we started her on BPC and TB4. And at the end of the day, she'd never needed a second injection of the PRP. So the peptides kind of helped to mop up the mess, as it were. I mean, she didn't make a full recovery, and I think that had to do with other reasons, but definitely that flap, you could literally see it repair. It was pretty cool.
It is. And it changed my daughter's life, obviously, because right, like nobody else was going to necessarily pick that up right away. What would have happened is she would have gotten a follow-up MRI because she wasn't healing the way they would have expected. They would have said, oh, shoot, we got these 2 big tendons that are torn. Now we need to go back to surgery and sew those together. And thankfully, I'm connected to Dr. Barrett, and he had the opportunity to do that for us. And now she's starting track season. And
that's amazing. That's so exciting. That's such a great story. Okay. Well, listen, why don't we use this as a natural ending point? I mean, clearly we can keep talking for a really long time. And I'm already extending a second invitation to you to come back and do another episode, which I think will be really fun. Maybe, in a few months' time, when you've been playing with the bioregulators for a little longer, and we can talk about that. I think that would be really exciting. So Dr. Vickery, why don't you tell people where they can find you if they're looking for you? Because I mean, I know I have a bunch of questions for you, although you're a very busy guy. So guys, don't be thinking you can just email the guest. But
so you can, my personal professional website for people who want to work with me individually or read some of the blogs I write and things like that is www.drgusvickery.com. That's drgusvickery.com. And then my practice in Asheville is called Wild Health Asheville. And my junior colleague here has a precision health program that includes genetics and labs and all of that, and health coaching at a lower price point than I am. So we have a lot of folks who work with us who are just trying to get their blueprints so they can have a better understanding of their body. I did publish a book a few years ago, which was like a summary of the philosophy of health I learned treating patients. It's really the elementary lessons. It was written for, if you're superhuman already, then this book, I guarantee you're doing 99% of it. But the people in your life who you can't figure out why they won't take action and try to get healthy, and the book is for them. It's helped thousands of our patients. It's a basic blueprint in a very simple way, how to begin to restore health, looking at, the whole the mindfulness piece of it, the stress piece of it, the sleep piece. I made that free. You can get hard copies on Amazon, Barnes & Noble, but I did make it the ebook free and the audio files free for anybody who wants it. And that's available. Yeah, it's available at a site called, it's not www, it's just ebook.drgusvickery.com. And you can get those audio files or that book. And I've gotten a lot of really good feedback that the simple style of writing and just for walking people through these basics in a really easy way has made a big difference for folks.
I love that. Thank you. I think that's a great resource to give people. So, I guess, I might ask you one final question. And you may have already answered this, but, if you could give people 1 or 2 things to really focus on, what would it be? What do you think are those 2 things? Or you could push it to 3 if you had to.
Yeah, I mean, like if I'm ever asked to say, give people one thing to do, like the number one thing to do, my answer is always go outside and play. Right. I mean, right, because that's going to take care of so many things, right? Going outside, natural sunlight, circadian rhythm health, right? All the things that it does for your brain, your vitamin D. Play, meaning having fun, joy, positive emotions, and likely if you're playing, you're getting physical activity, right? So that's like an easy one. Like you should spend more time outside and less time inside. It's critically important for your brain and for your overall health. I believe that obviously like you can't neglect any one thing, like your environment, your stress, all of them are important. But the two things that I see, I'm going to put sleep aside because we all know that one. You got to get good sleep. But the two things that are mostly impacting the health of the people that I'm seeing right now is their stress axis, their HPA axis. They don't recognize how stressed they are. And so the breath, the proper sleep, the mindfulness practices, the calming everything down, the high performing athletes, the recovery process, like focusing so much on that recovery because exercise is a form of stress. And then to the nutritional approach, right?
Yeah.
Like people. And what I think is most important, which is based on recent evidence, is the timing principles of eating, more so than what you eat, even though what you eat is important. And those are really simple. They came out of the Salk Institute, big trials. We finally have it pinned down. Do not consume food or beverage calories within 2 to 3 hours of bedtime. Don't consume food or beverage calories within at least 1 hour of waking. And if possible, consume your food and beverage calories with either an 8 or 10 hour window and have a 14 to 16 hour fasting window. Remarkable data for people who just followed that and didn't even change what they ate.
Yeah, that is amazing. Thank you so much, Gus. Thank you. I'm so glad that we made this happen, and I can't wait to talk again.
Yeah, thank you, Natalie. You've helped me so much too. So I'm very grateful for you.
Oh, back at you.